Hello, so I'm Bia Carlini, and welcome to the July webinar of Northwest ATTC webinar series. We are extremely pleased to have Dr. Joe Glass with us today. He is going to be, as you know, presenting on the topic of stigma. And Dr. Glass works at Kaiser Permanente, Washington Health Research Institute, and also is affiliated here at University of Washington to the Department of Psychiatry and Behavior Sciences. He has his clinical work as well as a licensed clinical social worker, and has currently a career development award from the National Institute of Health. Believe me, if you are a researcher, you know how hard is to get such an award and how prestigious it is. His research focuses on brief intervention in healthcare settings, stigma of substance use disorders, our topic today, and also health disparities. We are very pleased to have you today, Dr. Glass, and we are now transitioning to him to talk to us.
Good afternoon, everybody. It's a pleasure to get to present to you today as part of the NWATTC's webinar series. There's been some really impressive content since its began, and I'm really excited to be a part of it. And Dr. Hartzler and Dr. Carlini asked me to present to you on the topic of stigma, and specifically the impact of stigma on healthcare for people with substance use disorders. So kind of a disclaimer, I have a passion for this topic, having worked in the field and having studied it for quite some time. So I'm going to go ahead and get started. I'm having trouble advancing the slides.
If you click on the slide, you should then be able to use your arrow key.
Got it. Thank you. Okay, so here's the title. Okay, so first I have to acknowledge some important players, including the National Institutes of Health, which has funded my research since my dissertation, which was actually on the topic of stigma. And I also want to acknowledge my employer, Kaiser Permanente Washington Health Research Institute, which is funding some of my ongoing work on stigma and other things. And I also wanted to thank my mentors and other researchers who have collaborated with me to study stigma. The most significant and recent ones are listed here. First, Dr. Bruce Link, who's now at University of California, Riverside. Dr. Emily Williams, who's also at the University of Washington. And Amy Lee, who is a research associate here at Kaiser Permanente. And before I get started, one more thing. I didn't write it in the slide, but please note that the views in this presentation, they're my own and do not necessarily reflect those of Kaiser Permanente or the National Institutes of Health. And I also have no conflicts of interest to report. So let me orient you to what I'll talk about today. The main point of this presentation is to examine the stigma of substance use disorders and how it plays out in settings of healthcare. Whether it be primary care, specialty care, or social service settings. And I'll seek to address these three main questions. First, what is stigma and how is it relevant to substance use disorders? Second, what evidence is there regarding how stigma actually impacts care for people with substance use disorders? And third, how can we as stakeholders avoid perpetuating stigma when providing services, whether it be research or treatment to people with substance use disorders. This presentation, I'm hoping it's going to help people prepare people working in the field to have more empowering conversations and relationships with people with substance use disorders. And it could also help any interested lay person to avoid perpetuating the stigma of substance use disorders. And the content that I've prepared here, try to make it connect to other topics presented in the webinar series, especially those that focus on providing patient-centered care or providing evidence-based care to people with substance use disorders, who are a vulnerable population of people who deserve effective treatments and empowering non-stigmatizing therapeutic relationships. It goes without saying that there's a wide recognition among thought leaders, government agencies, that the stigma of substance use disorders is a problem and it obstructs recovery. Substance use disorders, which I'll refer to and includes alcohol and drug use disorders, they're among the most stigmatized health conditions, and they've been compared to other diseases such as HIV, cancer, diabetes, and a host of other health conditions. In a review of national studies by researcher George Schamres in Germany, he conducted a review of studies worldwide that have assessed what conditions out there are stigmatized and how stigmatized are they, and how do they stack up in comparison to other conditions. So essentially, he ranked what conditions were the most stigmatized. Across countries, substance use disorders are indeed among the most stigmatized health conditions. And the United States Surgeon General, which is an office that sets priorities for research and treatment throughout the United States, has described that there's been a long and continuing history of discrimination against people with substance use disorders. And the Surgeon General's most recent report, which was titled Facing Addiction in America, it does a really great job outlining how stigma has been viewed as a moral failure in the past and today still, and as a result has contributed to the historical separation between medical treatment and addiction treatment. Now today we're starting to realize more that addiction is a medical problem, and therefore its treatment must begin to be integrated more and more into mainstream care. And last on the slide, recovery organizations, which are the very institutions that seek to advocate and organize for people with substance use disorders, they're also working to tackle this problem of stigma, and they do it through various national and local campaigns. So in general, to summarize, stigma is a problem, and there's much agreement that it's an important issue that needs to be resolved. So the first part of this presentation seeks to address this question here. What is stigma and how is it relevant to substance use disorders? I hope to define stigma in some important concepts. So as you listen to these concepts, try to think about how you've seen them play out in the settings in which you've provided services or worked. So the word stigma continues to be used in so many ways. So I wanted to start with a few definitions and a few examples about what the word stigma really communicates. So this first bullet, this is paraphrased from Erving Goffman's seminal book titled Stigma, The Notes on the Management of the Spoiled Identity, written way back in 1963. Goffman defines stigma as a mark, attribute, or condition that society views unfavorably, and it leads society to reject that person. So this presentation is focused on substance use disorder being a condition that can be viewed unfavorably, and it's a condition that is used as a cue for society to reject that person. And negative stereotypes also play a role in stigma, and I'm sure you've heard of them. Stereotypes can be defined as their assumptions that are held by the general public about groups of people. We as humans apply assumptions to individuals, especially when we know very little about that person. We might only know that they're a member of this targeted group that's being stigmatized, and so then we'll apply all these stereotypes to them and make assumptions about them. These researchers, Crisp and Link, have studied stereotypes about addiction held by the general public. And some of the most common stereotypes that people with substance use disorders are that they're unpredictable, that they're dangerous, that they're irresponsible, that they're hard to talk to, and that they're generally of bad character. And a little bit about labeling. So labeling is also part of stigma. So what labeling is we affix terms or labels to groups of people to help set them apart from others. We do this to categorize people. Link was really careful to note that labels are culturally constructed categories. They're identified and selected by society, for their salience or importance. So in the case of substance use disorders, there's a few common labels I'm sure you've heard, such as addict, junkie, or alcoholic. The next term here, devaluation. So devaluation is when we assign less worth to groups of people or diminish the importance of individuals in that group because of their group membership. And discrimination is also part of stigma. This can include discriminatory acts by individuals, such as mistreatment of people with a stigmatized condition. But it also can include institutionalized discrimination, also called structural discrimination. And this is what we call laws or policies that exclude certain groups from benefits or provide a disadvantage to people with the condition. So I'll cover that a little bit more in a few slides. So a little bit about stigma in society. So some work has sought to understand, why is it that society stigmatizes people? Fallon and colleagues reviewed a body of literature on stigma and found 3 patterns. They found that the function of stigma is to keep people down, keep people in, and to keep people away. And I'll explain those. So keeping people in really refers to the written and unwritten rules about how people should conduct themselves. And so this would be the notion that stigmatizing people with substance use disorders would keep people from becoming addicted to substances. So if we stigmatize people with that condition, the notion is that it may keep other people from using more substances and thus meeting criteria for a substance use disorder. So keeping people away, that refers to attempts to keep people at a distance. For instance, one might agree that addiction treatment is really important and that we need it, but that same person might not want people coming for addiction treatment into their neighborhood. And the third function of stigma, keeping people down. So this refers to power, whether power or social status or even domination of a group. And so stigmatized groups in general, they tend to have fewer life chances. For instance, they're more likely to live in poverty, they're more likely to have less education, and go on to hold less prestigious careers. Another useful, So another useful way, this is the second bullet here, another useful way to understand the stigma of substance use disorders is to compare it with other conditions that on several dimensions, and these 6 dimensions defined by Jones. The dimension, I'll go through a few of these. So the dimension origin refers to where that condition came from. This dimension really makes addiction stick out from other stigmatized conditions. So for the most part, people tend to blame the person for their addiction more so than they blame people who have other conditions for having that condition. Some people still think addiction is a moral failing. They tend to ignore the biological or psychological causes or the social factors that lead to addiction, and that also impede recovery. This next dimension, concealability, this refers to whether the condition can be hidden or whether you can, quote, pass for someone without the condition. This is very true for many people with substance use disorders, and probably most so for people with mild to moderate substance use disorder. So they can, for instance, drink in the evening and have a substance use disorder, but go to work the next day and appear to function. I won't go over these other dimensions in great detail, but I'll say a little bit about them. The dimension course refers to whether people believe the condition is permanent. Disruptive is how disabling the condition is. And aesthetics or disgust, that refers to the actual emotional reactions that people have towards people with a stigmatized condition. And this last one, peril, that's how dangerous people with the condition are thought to be, which is another common one for substance use disorders. They're thought to be dangerous. So the point here is that these dimensions apply differently across different stigmatized conditions. And some dimensions are particularly severe for substance use disorders, and that should help us understand how addiction is stigmatized. Okay, so so how stigma affects individuals. So it can be easy to get lost in all these definitions that I just described. In Lincoln Phelan's pivotal framework, this helps show how these different aspects of stigma really work together. And so they describe that stigma as a social process whereby people are first labeled, and these labels serve to group people together in a category. And once people are grouped, stereotypes, or the consistent set of ideas about that group, are assigned, and these stereotypes tend to be negative. And this makes separation of that group much easier. There becomes an us versus them. Once a group is labeled and they're thought to be separate, it becomes easier for society to create rationale for discriminating against individuals or reducing their social status. And finally, stigma, this whole process of stigma is dependent on a power differential. And this power differential could be economic, it could be social, or political. And that power differential is really what allows this process to unfold. And without power differentials, in theory, this process of stigma would be interrupted. Okay, so now I'm going to switch focus from how stigma operates in society to how stigma affects individuals who have conditions that are viewed unfavorably. In particular, I'm going to start focusing more explicitly on substance use disorders. And so these are three key concepts. The first one is enacted stigma. This refers to the experience of being stigmatized. So these are the actual or perceived experiences of being rejected, being devalued, being discriminated against, or being stereotyped. And so in service settings, you may have heard a patient say that health professionals treat them differently or treat them worse once they find out that they have a substance use disorder. They might say something like, the patient might say something like, my counselor started ignoring my concerns once I admitted I used drugs. You may have heard that. The next key concept, internalized stigma. So this refers to what it feels like when stigma gets under the skin, so to speak. It's what goes on internally for the individual. So a strong indicator that stigma has been internalized is when somebody starts to feel ashamed or they start to feel inferior specifically because they have a substance use disorder. So a quote that represents this is that someone might say, why can't I just quit using substances? And therefore, they think they're such a failure. The next concept, anticipated stigma. This is when someone knows about the stereotypes and discrimination that's out there in society, and they expect that this stigma will happen to them or will happen to others who are in the same stigmatized group. So this is a big one that's thought to keep people with substance use disorders from seeking help or telling others that they have a substance use disorder. For example, someone might say, my counselor won't listen to my concerns if he or she knew I used drugs. So I'm not going to tell them. So these citations at the bottom, the first one is for the stigma framework that has categorized these three types of stigma experiences from the perspective of persons with stigmatized conditions. And the next citations, which in the full citations are in the last few slides, so I encourage you to use those as a resource. This is for research, including some of my own, that's linked these types of stigma with poorer outcomes among people with substance use disorders. So just a few examples. In research, when we assess these types of stigma in surveys, people with substance use disorders who score highly on any of these three measures, they tend to report more social isolation, less confidence in their ability to refuse drinks, and they also report more depression and anxiety. They also tend to be more likely to conceal or hide their substance use or to drop out of treatment earlier. So this really suggests that these types of stigma are really a real phenomenon, and we should be concerned about them in practice when we provide services. Okay, so this next slide is about what is often called the social ecology of stigma. And This really what this tries to point out is that the stigma of addiction exists at multiple levels. And so the structural level, which I mentioned before, this includes the laws and policies that exclude people with substance use disorders from certain privileges, or it makes things harder for them, such as accessing services. Some examples of this include limitations or exclusions from assistance with nutrition, with housing, with employment help, or with student loans, or any other type of benefit assistance. So those things still exist today. And people with substance use disorders are still not protected under anti-discrimination laws, such as the American Disabilities Act. So that's the structural level. In this image here over about budget cuts, I mean, it's common for when government level budgets are cut for stigmatized conditions like substance use disorders to be on the chopping block first. So now for the social level. So this is where people with substance use disorders encounter much stigma in their day-to-day life, in interactions with other people. And so they might hear negative attitudes, they might hear stigmatizing opinions in regular daily exchanges, including especially on social media. And at the individual level, that's where internalized stigma operates. So as a result of all these negative experiences in the environment, from being discriminated against, from hearing the negative things that people say, that's when people start to feel ashamed or unworthy because of the stigma. And that has a huge effect on their quality of life and on depression and anxiety and many other things. Okay, so now on to the next segment of this webinar. So the second part focuses on the current state of the evidence about how stigma impacts care for people with substance use disorders. So I'll first show you studies about stigma that have tried to explore how stigma impacts health professionals. So this first is a series of 2 studies by John Kelly and colleagues, and these studies are now pretty famous. So you may have heard about these before. So the motivation for this is that there's been a notion that if health professionals hear stigmatizing language when they hear case presentations, it could bias their decision-making and make them treat those patients differently. So what this study did is they wanted to know if clinicians might make different decisions if they were told the patient was a substance use disorder, or I'm sorry, if they were told patients was a substance abuser versus if they were told the same patient had a substance use disorder. And so as you see on the screen, these 2 vignettes have the exact same text, except for the first vignette has the word substance abuser to describe the patient, where in the second vignette, that was swapped for substance use disorder. So I'll read the first one to you. Mr. Williams is a substance abuser and is attending a treatment program through the court. As part of the program, Mr. Williams is required to remain abstinent from alcohol and other drugs. He's been compliant with program requirements until about 1 month ago, when he was found to have 2 positive urine toxicology screens, which revealed drug use, and a breathalyzer reading, which revealed alcohol consumption. Within the past month, there was further urine toxicology screens revealing drug use. Mr. Williams has been a substance abuser for the past few years. He now awaits his appointment with the judge to determine his status. So notice the 2 instances of the word substance abuser in there. And I'm not going to read the second one, but the only thing that has been swapped is the term substance abuser to substance use disorder. So what did they find? Before I show you the findings, I just wanted to comment on the study design. So the study used a rigorous design. What they did is they recruited 516 doctoral level clinicians, and they used experimental methods. So what they did is they randomly chose which of these clinicians would see which vignette, and they chose that randomly. And then after the clinician read the vignette, they were asked how much they agreed with a number of statements. And so what they found was clinicians felt differently about the patient depending on the language that was used to describe the case. So clinicians in general that read the vignette that labeled the patient as a substance abuser, they were more likely to agree with the statement that the patient should be punished and that the patient is to blame for their condition. So this graph shows results from the second study by Kelly and colleagues in that same year, which presented similar vignettes to the survey respondents, but they did not use an experimental design. And so in general, the results were really similar. For instance, clinicians thought that patients described as having a substance use disorder were more likely to benefit from treatments than patients who were described as being a substance abuser. And that can be seen here on the left bar and the black shaded bar that shows the score or the rating for the vignettes that were presented as the patient having a substance use disorder. And the white bar shows the score on the vignette where the patient was described as being a substance abuser. And a higher subscale score means that that from the perspective of the person completing the survey, they thought that that patients with substance use disorders were more likely to benefit from treatment. And so I won't describe these other ones in detail, but you get the picture here. So the clinicians who were presented with a substance abuser vignette, they thought that punishment was the best course of action. Okay. So this next study, another piece of evidence, is a more recent one that tested a similar concept, and from a little bit of a different angle. So as treatment professionals, we're constantly exposed to written information about patients when we review patient histories and medical charts. So this study was interested in whether exposure to that stigmatizing language and chart notes could potentially affect clinicians' attitudes about patients and could affect their clinical decision making. So the study used similar methods as the previous ones that I just described, except that the researchers presented two vignettes that were adapted from an actual chart note. In one of the chart notes, they modified to have stigmatizing language. In the other one, they modified to use medically accurate language to describe the patient. So they presented one of these two notes at random to over 400 trainees at different levels. And again, the trainees who were exposed to the note with stigmatizing language had more negative attitudes towards the hypothetical case than those who were exposed to a note with medically accurate language. So I think this study raises a critical issue, and this issue was nicely summarized in an editorial written by Dr. Sean Robinson at VA Puget Sound in Tacoma, where he talked about the fact that we really need to be mindful of the bias that can result when we read other people's chart notes, when we read our colleagues' chart notes about a patient. And we also need to be mindful about the language that we use when we write chart notes about patients, because they could affect decision-making in the future. Okay, so this next study that I'm going to summarize switches gears to two important topics about empowerment and collaboration. The researchers here sought to understand how empowerment and collaboration play out in treatment settings. And so to do this, they conducted in-depth, semi-structured interviews with 54 people. And these people were clinicians or patients in inpatient, outpatient, or residential alcohol and drug treatment facilities. And these were facilities in Australia in a metropolitan area. In these interviews, what the researchers heard were many perspectives on how stigmatizing beliefs held by clinicians were brought into the treatment setting, and how much of a negative impact these beliefs held by clinicians had on empowerment and collaboration. And so they heard a common theme that people felt that treatment had this negative impact, and I'll describe these themes. So one of the themes was that there was a noticeable power differential between clinicians and patients, and what they called dividing practices. And these were unsaid categories that were created to group patients into good or bad patients that were in part based on moral grounds. So patients reported that they felt disempowered, and particularly by all the rules and regulations and restrictions imposed by clinicians and by that specific treatment setting. And specifically, they mentioned that they felt this way because a lot of these rules were imposed without providing rationale or providing justification for why there was that structure. So in essence, the patients felt their autonomy was stripped away. What was also interesting is clinical staff also felt disempowered. And this really came up when there were conflicting philosophical perspectives with respect to whether or not to treat patients with harm reduction strategies. And so there are differences among staff about what they believe was the right approach. And so in essence, the researchers of the study, they really recommended that treatment settings should pay more attention to their policies, try to increase transparency in those policies to avoid misunderstandings among patients and to be more transparent, and also to encourage staff to provide them time and strategies to reflect on their own attitudes and how those attitudes affect their practice. So this next study that I'm going to describe is what's called a systematic review. It's really a method where researchers carefully select a body of research on a topic that's thought to be representative on that specific topic. And they sought to describe what's known about health professionals' attitudes towards patients with substance use disorders. And they also want to know what evidence is there that these negative attitudes have a consequence on patients. They identified 28 different research studies that had been published at the time of this study, which was published in 2013. So their findings, in addition to some of the research studies shown on the bottom left-hand corner of the screen, in general, what they found is that, yes, stigmatizing beliefs and negative attitudes are common among clinicians. Which I don't think is too surprising. I mean, because clinicians are people, and the same is true for the general public. However, some of the concerning findings were that clinicians who have stigmatizing beliefs, they often spend less time with patients with substance use disorders, and that was particularly true among nurses who had less education about substance use disorders and held a lot of assumptions. They also found that relationships were less collaborative when clinicians had more stigmatizing beliefs. And patients did report decreased engagement and decreased satisfaction with care when stigma was present. But there is a caution here that, the effect of clinicians' attitudes on patients, it really is an understudied topic, and we really need to learn a lot more about this. New research is needed to confirm some of these findings and to see how definitive they are. Okay, so more recent research. So that was a little bit older of a review. These studies are more recent, and what they've continued to study is this problem or this question about whether clinicians' stigmatizing beliefs have any effect on the provision of care. And in particularly evidence-based care or evidence-based clinical guideline recommendations. So this research, these studies include two qualitative studies that use in-depth interviews, as well as a survey study that evaluated whether stigma impacted decision-making or attitudes towards adopting new evidence-based practices. And these studies indeed suggested that stigmatizing attitudes among clinicians they do seem to have an impact on their decision to conduct services such as population-based screening for substance use, and it could affect their decisions to implement FDA-approved pharmacotherapies or medication treatments that are evidence-based and they're recommended for alcohol use disorder. Okay, so now for the last piece of evidence that I want to present. So this shifts the focus away from professionals and back onto the people who might benefit from utilizing addiction treatment services. So people in the community with substance use disorders. As you may be aware, the vast majority of people with substance use disorders just never seek treatment for their problem. And there's a number of reasons for this, which I won't go into today. But the specific study sought to answer the question, are people with alcohol use disorders less likely to utilize treatment services if they perceive more stigmatizing attitudes towards this condition or towards alcohol use disorders? So the authors, what they did is they analyzed data from a nationally representative survey of over 40,000 people in the United States. And in that survey, about 6,300 met criteria for DSM-4 alcohol dependence at some point in their lifetime. And the survey also assessed a form of anticipated stigma, or the perception of that people with alcohol use disorders will be stigmatized. The survey also assessed whether or not survey respondents ever received help for their drinking. So they asked them about receipt of professional services and 12-step groups and other informal types of care, such as at social service agencies or by clergy. And so let me orient you to what the study found. So this table, I'll try to walk you through it. So this table shows that 1,401 of the 6,309 survey respondents who had a lifetime alcohol dependence ever received treatment in their lifetime. So they grouped these people, they grouped all persons who met criteria for alcohol dependence in their lifetime into 4 categories based on their responses to the Stigma survey. So these 4 categories are in the rows here. The first is those that perceived a high amount of stigma towards people with alcohol use disorders. Next, those that perceived a middle-high amount, a middle-low amount, and those that perceived a low amount of stigma towards people with alcohol use disorders. And what the findings show here in this red box are that people who perceived a high amount of stigma were about had about one-third the odds. In other words, they were 0.37 times less likely than those who perceived a low amount of stigma to receive treatment for the drinking. So in other words, there was an association here, and the association was that people who are concerned about the stigma of alcohol use disorders may be less likely to access treatment. So I will say that this is a cross-sectional study, and there's a number of limitations to asking people at one point in time about things that happen throughout their whole life. There's a lot of retrospective recall bias, but nonetheless, this is preliminary evidence that this could be a problem. And these citations at the bottom try to kind of unravel why this. They're on a similar topic, and they help unravel why this may be so. There's a lot of research on there trying to explore, well, it could be common sense would say that that people don't want to go to treatment because they don't want to take on that label of being a so-called alcoholic, or they don't want people in their community to know that they've gone to treatment, or they may feel it's a sign of weakness. Some of these other studies have directly asked people, well, why didn't you go to treatment? And in those studies, stigma is often, stigma or stigma-related topics are often one of the most common reasons that people say they don't go to treatment. And I will say this last study listed here, this Ober et al., that study looked at a different kind of stigma. Rather than looking at perceived stigma, they looked at internalized stigma. And they wanted to know, are people with more internalized stigma, are they more or less likely to get treatment? Well, they found, at least in a primary care population, people with more internalized stigma, they were actually more likely to get services for their addiction. So this is something that's hard to study, and I think it really depends on what type of stigma it is, what population you're investigating. So again, this is something else that needs a lot further study. Okay, so now for the third and last section of the presentation. So what I'd like to do is try to shed some light on the question. So how can we as stakeholders avoid perpetuating stigma when providing services to people with substance use disorder. And what I would say is perhaps the easiest way to avoid perpetuating stigma is to try to use accurate and non-stigmatizing language when we talk about addiction or when we write about addiction. And when we think about writing about addiction or talking about addiction, this happens in a number of venues. It could be in our professional settings, it could be, op-eds, it could be a research article, it could be a chart note, or it could be just in conversations among friends and family members. My guess is that if you're listening to this presentation, you yourself are probably an expert in substance use disorders, and people look to you as being the expert. And so what I'll say first about language is the HIV treatment arena has done a great job at seeking to change the way that they use language. And they've done this targeting both clinicians, educating clinicians, and the general public. And so shown here on the left, this is a popular infographic. You may have seen it before. And what I like about it, it's really simple, and it attempts to really educate people about how to avoid language mistakes. And it uses language mistakes. It's not saying that people who use the wrong words are bad. It recognizes that we all make mistakes in the language that we use. And so here are a couple examples from that infographic on the left. So it's a common mistake to conflate the diagnosis of AIDS and HIV. They're different diagnoses. And many people, when referring to HIV, will just say AIDS. And so, this is just a simple reminder. Actually, when you're talking about HIV, refer to it as HIV. Another simple one here on the bottom is rather than calling somebody an AIDS patient or an HIV patient, this is really common in chart notes, call them a person who is living with HIV. So use person-first language. So person-first language really emphasizes the person is the primary part of the conversation, and the diagnosis is the secondary part of the conversation. And so this table on the right is essentially saying the same thing. I added this here because there's a certain part of it that I really like, which I'll highlight right now. So in this last row, it's about the stigmatizing term full-blown AIDS. So really what the point is here is that there's no medical definition for this phrase. So why do we use it? What does this communicate? So without a proper medical definition, without a current medical definition, there's really not a point in using it, especially if you're a professional. So I think, what the take home from this is, if what you're saying, asking yourself the question here is what you're saying accurate, and is it based on a currently accepted medical condition or medical definition? So if it's not, then another term should probably be used to avoid confusing patients, to avoid confusing your colleagues, and to avoid confusing other stakeholders. Okay, so what might be the right way to say things? So, again, this is my own opinions on this topic. I think they're shared by many other people, but here's what I have to say. So here's two simple guidelines. First, when referring to behaviors or conditions or people with substance use disorders, use language that's medically accurate and that's current. So for instance, say substance use disorder instead of substance abuse. And there's a couple ways that substance use, where the use of that term goes awry. So first of all, people commonly use substance abuse to refer to this whole concept of addiction, which is problematic for a number of reasons. So, I would ask yourself, are we really referring to people who are diagnosed with substance abuse, people who meet greater than or equal to one of the 4 criteria of DSM-4 substance abuse when we say this? If we're not referring to that specific instance, don't use that term. Also consider that DSM-5 no longer even has the diagnosis of substance abuse, which is so thus, this term is going to really cause confusion. So second is to use person-first language. And I talked about this already, but it really places emphasis on the person instead of the diagnosis or instead of the label. And so an example of this is to say person with a substance use disorder instead of substance use disorder patient, or instead of addict. And so here are some other common things to avoid that, I'm sure you've seen quite a bit. So negative labels such as alcoholic, pejorative language, so this person smells like an ashtray, or loaded attributions that imply blame for the cause of the condition, or that they could control the condition if they wanted to. So this example is, oh, they could quit if they wanted to. And then last, this is kind of so the last, try to avoid communicating with a negative sentiment or negative tone in your verbal or nonverbal communication. So in your clinical documentation, somebody might say something like, one of the chart reviewers here has seen notes that say something like, oh, this patient came in their, Victoria's Secret outfit. And like they were trying to imply, it seemed like the author of that note may be trying to imply something about the patient that's really not specific, and it's really vague, but it seems to be implying something negative, a judgment about that patient. Okay, so this next slide, this study here is kind of provides, it's another study, went into it in depth, but this is newer evidence published in 2018 by researchers out of University of Pennsylvania. What this research study is really attempting to do is just to provide more support that what we say is important. So in addition to the prior studies that use those vignette methods to show that it really does matter how we say things, here's a more recent study on this topic. So they use an innovative computer-based assessment technique called implicit associations test that I won't go into. But what they found was that several common stigmatizing terms that are used to describe substance use disorders were found to be much more negatively charged than other interchangeable terms. So the terms like addict, alcoholic, opioid addict, substance abuser, they had a more negative charge to them, and they assessed that through computer-based methods. Okay, so this kind of tries to sum up this discussion around language. So I'm going to leave you with this table. It attempts to provide some preliminary guidance, and I will emphasize preliminary, about things that we could say. And again, this is based on the opinions and consensus of me and other colleagues. It might not be right, but this is what we're putting out there. So these terms were based on an initial search of the literature. I also conducted an expert query by emailing thought leaders in this area. And I also vetted these terms with two of my brightest colleagues, Emily Williams and Amy Lee. So we tried to use a systematic method for classifying terms as stigmatizing. So that's what we've done here. Is on the left are stigmatizing terms that we recommend that you try not to use. And on the right are preferred language, so use this instead. So again, this is a works in progress, but I encourage you to take a look and think for yourself. How does this fit for me, and how does this fit for where I practice? And the last thing to note is that the accuracy of terms does change over time. So something like this should never be thought of as a static document that shouldn't change. Okay, so this topic here on patient-centered care, it was exhaustively covered in a previous webinar in this series. I also did want to point out just how relevant it is to reducing stigma and increasing empowerment of patients. A lot of these things really reflect the general spirit of motivational interviewing, and also the concept of shared decision-making in medical practice. And if you pay attention to these things, it's likely to improve relationships with patients, improve collaboration, and empowering patients. So combining these things with the use of accurate language will likely be fruitful and will likely help patients. Okay, so that's all I have today. What I want to do is just cycle through these references slides really slowly, and these will be available online with the slides. So that's all I have. Thank you.
Okay, Dan, thanks so much for this very, very thought-provoking webinar, Dr. Glass. We are 7 minutes to the end. We'll, if you are available, maybe stick around for 3-4 minutes after the end to be able to get some questions answered. But before getting to questions, it will be very, very helpful for people to respond to our surveys. That's the way we keep doing the work we do. So right after this, you're gonna get a short survey right after we finish, and also you're gonna be able to access the PowerPoint and the webinar. And in a month, so that's a little far out, we are gonna send another one. But this is requirement from our reporting. I hope you can help us out. Okay, so let's get questions now. We are just opening questions now. We didn't see them as they were coming. There are many of them. I'm gonna start reading, let's see how many we have here. Okay, yes, the slides are available, right? You guys know that. Okay, so there was one question that says, have individuals expressed their reasons as to why they continue to use controlled substances if they don't like having that negative stigma? Also, does the feeling of personal shame, negative societal stigma, etc., help motivate individuals to seek help to break their addiction?
Okay, could you repeat the first part? It seemed to be 2 questions. Could you repeat them?
Yeah, okay, so let's start. Have individuals expressed their reasons as to why they continue to use controlled substances if they don't like having that negative stigma?
Okay, so I'm not totally sure if I understand the question, but let me paraphrase it, and maybe you can tell me if I'm getting it right. So is the question, when people feel stigma about substance use disorders, does that make them decrease their use? Is that the question?
Yeah, why people know they have stigma and yet do not change, continue to use the substances?
Yeah, that's a really great question. And so, I mean, I think this really relates to the concept of keeping people in. It's a type of norm. Stigma is a type of norm enforcement. In theory, there's criminal justice theories that if people know that they're going to get punished, it should change their behavior. What's really interesting is this is actually something that I've been looking for in the past decade that I've been studying this topic. And I have now not found any conclusive evidence at all that stigma prevents people from using substances. In fact, in some of my own work, I found evidence that that's not true at all, and that hypothesis wasn't supported. And to the contrary, while we don't have evidence that stigma causes people to not use substances, we have a lot of evidence that among people who have a substance use disorder, stigma interferes with recovery. So there is some cross-sectional evidence that stigma is associated with not ceasing their use of substances. And so there's one of the Glass 2013, in the title is Modified Labeling Theory. That article addresses that topic.
Okay, thank you very much. We have several questions from the same person that had a double question, so I'm gonna try to go to a different participant. So another question is, in the Kelly study, did they recruit PhD clinicians with prior experiences on substance use disorder, or those who have primarily treated mental health conditions? I'm wondering how prior experience with SUD may have impacted the stigma.
So that's a really good question. So So that Kelly study, they recruited PhD level clinicians. I believe it was at a mental health conference, and so I would assume that there would be a mix of providers in there, but I would have to double check. So I would encourage you to email me that question, and I can look for you. Or you can check out that study online. The citation is in the slides. What I will say is that that study used randomized methods. And so it randomized each individual clinician to what vignette they would see. And so what that randomization does is it makes those two groups equivalent. So if there were a mix of people with and without experience in substance use disorder treatment, that would be equivalent across groups, and they compared those groups. And so that I wouldn't consider that to be a concern. But it would be a concern if none of those clinicians had experience in substance use disorders. And what we would say then is that we just need another study in that different population of professionals to see if those findings generalize. That's a great question.
Good. Okay, I'm gonna finish with the last one, and we're gonna make these questions available later, Dr. Glass, for you to respond or not, depending on your ability. So here goes. 12-step programs always ask their members to introduce themselves as addict or alcoholic or compulsive gambling, along with their name. Should this change, or how does this help them in their recovery?
Yeah, I really love that question, and that's actually come up multiple times when I've talked on stigma. So here's my opinion, and I've given this response to multiple people in the recovery community, and they've seemed to agree with it, but I'm not saying everybody would agree. So the term addict is stigmatizing, but also it is used by people in Narcotics Anonymous or Alcoholics Anonymous, the term alcoholic. And so there's a lot of literature out there about well, first of all, why would it be beneficial? Really, it has to do with the fact that it creates a group. It takes this concept of a label and it spins it in a positive way. So it helps a group of people identify with each other. So what I would say is, if you're a member of Alcoholics Anonymous or Narcotics Anonymous, and this term is being used and it helps group members identify with each other and relate to one each other, I think that's a great thing. However, where I think the term is misused is when somebody who is not part of that group uses that term to refer to either people in that group or people who don't identify as addicts. And so that's where I think the term is the most harmful. So it is an interesting, it is an interesting thing. And I think it's a case where the term is both good and bad. But I think as treatment professionals, we shouldn't try to push terms on people. If the recovery community wants to do that in an effort to band together, then I fully support that.
That's great. Okay, we are a minute past. Thank you so much again for your participation. And we want to announce the next webinar. Thank you so much, Dr. Glass, and everybody. This is a record on attendance. And we hope to see you in our next webinar that is going to address youth substance abuse in the juvenile justice system. Thanks so much. We are going to send the questions afterwards.